Everybody, I'm Brittany and today we're going to talk about the Not on Tobacco program. The Not on Tobacco Cessation program, or NOT as we're going to refer to it throughout this presentation, is an intervention provided in a school setting. The program consists of 10 50-minute to hour-long sessions provided about one time a week for 9 consecutive weeks. Most of the adolescents in the programs are in rural or suburban areas, and adolescents in the program are able to speak and read English. Individuals who lead the program are certified facilitators through the American Lung Association. The target population for the NOT program is adolescent smokers, and those adolescent smokers attend public schools and are voluntary to the program. NOT identifies the main goals of the program as helping adolescents to stop smoking and stop making excuses by understanding why they smoke and how to quit, along with skills on how to overcome nicotine addiction, the benefits of quitting, stress and weight management, and a focus on how to stay smoke-free for good. My question regarding the Not on Tobacco program is whether the program is effective for individuals who suffer from mental health issues. Let's look at a few determinants of health for this program. Gender is an important social factor when you're looking at smoking. Adolescent females and males may have different social pressures to smoke, and that's extremely important when you're developing a program to impact smoking. The NOT program divides participants into 2 different gender groups, male and females, and the facilitators are same-sex facilitators for those groups. The facilitators are provided tips and tricks on how to deal with each gender, and the curriculum is gender-specific. Developmental level is also important when developing a curriculum. The curriculum should not be an adult curriculum that is tailored towards adolescents, which is how many cessation programs had done it previously to NOT, but NOT is using a curriculum developed specifically for adolescents with group activities, journaling, and hands-on activities that help the adolescent crowd remain engaged and retain information. Another important determinant is stress. Stress levels have a big influence on smoking and how much people smoke, and NOT addresses that issue by incorporating stress management into every piece of the curriculum throughout the 9 weeks. Lastly, a determinant not listed here is around mental health. Facilitators have highlighted that participants are likely to present with a wide range of mental health issues that extend beyond smoking cessation. The NOT program includes a referral protocol for facilitators to ensure that adolescents have access to professional mental health care that they may need. When we're addressing community concerns, the biggest community concern that NOT is addressing is around the high prevalence of young smoking ages in rural and suburban areas. Now, that is, of course, compared to urban areas. When you look through all the research, it is much more likely that teens or adolescents in rural areas are going to smoke at younger ages than their metropolitan counterparts are. And that's the largest community concern that brought NOT to the rural areas. When we're looking at infrastructure, the most important key players to highlight is the West Virginia Prevention Research Center, who formed a partnership with the West Virginia State Health and Education Departments, the Coalition for a Tobacco-Free West Virginia, and the American Lung Association to develop a plan to reduce teen smoking. Of course, the plan they produced was NOT. On the multidisciplinary team, you're going to have academic researchers who are responsible for epidemiological reasons for a study and provide evidence of outcomes once the program is piloted. There's going to be community outreach and education workers who are responsible for engaging the communities that they want to pilot not in. And then there's going to be policymakers who are responsible for ensuring that NOT has funding and that NOT is also backed by policies to allow it to spread into additional communities. The researchers and scientists that I'm referring to here are those that write the articles and do the experimental studies or quasi-experimental studies on NOT to prove that it's an effective program. And we're going to talk a little bit more about the community members and school personnel and how they are part of the team. But mainly, community and school personnel are going to play a lot of roles throughout this presentation. One role is a school and any school in the community that NOT is going to be implemented in is an external stakeholder. Schools provide the location, participants, and more often than not, the facilitators for the NOT program. Communities are also key and external stakeholders here. The communities have that big concern, as we discussed, around high smoking rates of the rural adolescents. And so communities have a big need for NOT to come and produce these strong results in smoking cessation. And another external stakeholder is the participants in the program. They're voluntary and they've identified that they want to quit smoking and that they have tried to quit smoking previously. And so they are going to really be drawn to getting the most out of the NOT program. So again, schools play another role here as a community resource. As we talked about, schools are providing a lot for this program. They're going to need to provide a space either at two different times or two different spaces because as we discussed, there are two gender groups that the program is implemented with. The facilitators are the community individuals I'm referring to. They provide all of the information to the community. They attend a train the trainer, and then they get all of these training materials and they bring the program to their community. So a lot of their time is invested into the program. Additionally, the community provides the willing participants, the voluntary adolescent smokers. And another less noted but very important community resource is businesses who may produce signs, literature, educational materials in order to get the word out there about the NOT program. When you discuss funding for the NOT program, what you're really focusing on is the multiple grants. And there are several grants that are funding NOT, but the CDC is the largest grant and the one I want to highlight for you. I think the CDC grant, and that's the Center for Disease Control Prevention Research Center grant, is important because in order to receive this grant, programs had to produced one or more positive behavioral or psychosocial outcomes among individuals, communities, or populations. And evidence of those outcomes have to be demonstrated in at least one study using an experimental or quasi-experimental design, among many other requirements. But I think that's an important thing to highlight because in order for NOT to have received this grant, basically the program has to work. And so it really helps bolster the program's credibility by being backed by such an important grant. So anytime we are working with minors, there's of course some ethical concerns that can come around. So something really important to highlight here is around active parental consent. the U.S. Department of Health and Human Services require that researchers obtain legally effective informed consent. So that means they had to have told all of the research subjects about the purpose of the study, description of risk and benefits, and other critical information. Now, the way the NOT program receives consent is through a passive parental consent process. And that's an exception to the active consent rule because NOT is in a school setting. So all that NOT has to do is send home the information, and guardians or parents only send back a letter if they do not want their youth or adolescent to participate. So they don't have to sign in an active parental consent role. Now, there's not been any complaints or incidents about this process, and it's actually had some highlighted benefits such as reducing labor costs, but it could come up as an issue, and so it is something to highlight as a potential ethical concern. Another ethical concern is around a minor's decisional capacity. Decisional capacity is someone's ability to understand treatment and then make an informed decision about that treatment. And in this case, if parents aren't actively declining their minors, well, they are actively declined, but if they're not actively consenting to their participation, who's looking out for a minor's best interest? And additionally, minors can just avoid taking the letter home to their parents, and so parents may never have seen the letter at all. Another ethical concern, especially for the NOT program, is around facilitators' delivery of the program, and so basically a fidelity to the model. There are significant risks posed by interventions that are poorly implemented in these areas, such as those that emphasize confrontation and fail to establish an alliance with clients, and those that lack goal direction and clarity. Now, the PRC, as we mentioned earlier, provides scientific oversight, technical assistance, data management, and evaluation. But unless facilitators are engaging and goal-driven in their delivery of the program, there's an ethical concern that the program won't be as effective as advertised. With that being said, any program comes with its opponents. So let's take a look at a few of NOT's opponents. One is the tobacco industry. The tobacco industry is a little infamous for targeting the minor population, younger generations, through maybe fun-flavored cigarettes or other marketing techniques, and not really aims to give those adolescents skills to stop smoking and prevent smoking from transitioning into adulthood. With that being said, the tobacco industry would be losing their adolescent market, but then they would also be losing their adult market as NOT spreads because those adolescents are no longer smokers in their adult ages either. Another opponent could be teachers. Teachers may oppose a student missing class time, may be concerned about a student's grades if they're participating in the program, and teachers not wanting students to be taken out of class was actually identified as a recruitment barrier for the NOT program. Lastly, parents may be a potential opponent. Although this has not occurred yet, parents who don't want their kids to participate in this type of program, don't want their school to know that their child smokes, or may not see an issue with their child smoking, could be opponents. If a parent decides that they are not comfortable with the passive consent process, those parents may also become opponents. Or if active parental consent is suddenly required by DHHS, you may see a lower involvement because the parents are opposing the program. So let's take a little bit of a gander into the political, social, and economic factors of the NOT program and why it came about. One of the big ones that I've focused on and is still extremely important is around teen smoking rates. Teen smoking rates are really high, but additionally, those teen smoking rates lead to health issues, and oftentimes individuals with those health issues either can't afford health insurance, may not be able to obtain health insurance due to pre-existing conditions, and so that cost falls on taxpayers and causes an overall public health issue for our nation. A big social factor of the NOT program is around the impact of peers. The NOT program really aims to impact the risk factor of frequent hanging out with friends and having friends who smoke. The NOT program really is developed to impact a teen's ability to quit smoking while still living within their social groups. But where NOT was piloted, the target was those peer groups themselves. So the individuals who were attending NOT were peer groups that were smokers. And so NOT was able to reduce the overall smoking rate in peer groups, which is extremely impactful. So, an economic reason that NOT is so important is how cost effective it is. It's not only cost effective because it's aiming at teen smoking, and teen cessation programs are not only more successful than adult smoking cessation programs, they are also more cost effective. But additionally, because NOT is school based, it produces long term results with a smaller amount of resources, making this program extremely cost effective for the community that it's in. So, knowing all of that information about NOT, there's a really important way to market and deliver it to communities. And I believe that would be through social marketing. Social marketing is the application of commercial marketing technologies to the analysis, planning, execution, and evaluation of programs designed to influence the voluntary target audiences. So basically, you would highlight some factors from NOT that are of great interest to that community. So I would focus in on the effectiveness, peer group approach, and the fact that adolescents don't need active parental consent in order to engage teens in it. I would focus communities on the short term lower school suspension rates, long term effects on taxpayers, being that they don't have to pay for those healthcare bills, and of course, the long term results of the smoking cessation itself. Now, with all of that being said, that's going to engage the community who's already identified the issue and give them a program that meets all of the things they've identified. But because of the way NOT is implemented, it is done with facilitators from the community who engage other community members to support the program, which means that the change itself comes from within that community. And that's really the goal of social marketing, is to market a program that makes the solution the community's solution, not the professional solution. So let's look at why this program is so successful. One being NOT is focused on process. Most programs are focused on content. NOT is really focused on the implementation and process of the delivery of the program. They really focus on those train the trainer workshops that I discussed. They focus on making sure that the facilitators are well trained to implement the program. And because of that, the focus really helps not produce those long-term results. The focus on gender is really important to the KNOT program. Previously, cessation programs didn't really focus on those gender groups like we talked about, and that's one of the reasons that KNOT is so impactful. Participants really report enjoying and feeling more open in those gender groups than they do in other programs. KNOT also focuses only on smoking. Previous programs have focused on using a curriculum to address all different types of tobacco use. However, high school teachers, counselors, and even teens indicate that users of different types of tobacco products belong to very different groups and have very different interests. So they're not really using that peer approach in the same way that KNOT is using it. And lastly, like we discussed before, KNOT is extremely cost effective based on the low implementation cost and the high result production. So some short-term and long-term effects that you're going to see from this really highly effective program include high retention rates. The program uses a lot of incentives to keep participants engaged, and it's really proved very effective for this program. A negative short-term effect of KNOT might be that smoking status is now clear to the school. It can't be used against participants, but it could create a bias on the campus towards those students who smoke, and it may make students uncomfortable if teachers didn't previously know that they were smokers. Some long-term positive effects is that both facilitators and participants report having positive experiences. Participants report enjoying having a community member that they are engaged with, and facilitators report that their time was worth the investment. Additionally, a long-term effect is that 20% of participants report quitting smoking at a 3-month post-baseline. And overall, in the regions where KNOT was implemented, 5 out of 8 had upward reports of cessation, which is actually above national program effectiveness data. I wasn't able to find any reported long-term negative effects of KNOT. I don't know if that is because KNOT has not been studied in a long-term version of a research. I am interested to hear if my cohorts were able to find that in the literature. I was able to find a long-term and short-term positive effect, which was stress reduction. It's highlighted throughout my presentation that in each part of the curriculum, individuals really focus on learning stress reduction techniques, but the program also teaches adolescents how to transition those techniques into school, peer, home life. And so that allows them to use that throughout adolescence in all different aspects and may even transition into adulthood with how to handle some situations. So let's look at the scalability of KNOT. KNOT up until this point has been utilized mainly with a homogeneous population. They're mostly white in the same age range, have the same smoking start ages, and voice a desire to quit. If KNOT is going to move into communities with a similar participant and community makeup, the program is definitely scalable. However, Horn suggests that the program does need to be implemented in differing communities to analyze the program's continued effectiveness. by attempting to change interventions to meet those populations' needs. So that's not to say the program can't be scaled into those communities, but it's going to take some changes in order for the program to be successful. So Horn suggests that the program consider facilitators who can relate to individuals from all backgrounds and to incorporate culturally sensitive material to be successful in those new environments. A really important thing to note is that the participants in those communities need to be informed that the results may differ in their community than it did in the previous ones. Basically, they're almost like new pilot sites for the program at that point. And so, although we can scale the curriculum there, the implementation may have different results. So, let's circle back to NOT and mental health. I only mentioned it a few times in the presentation, and that's because overall, NOT really didn't have a lot of supporting evidence that you could use it with somebody with a mental health diagnosis who was a smoker. As a matter of fact, Horn actually highlights that NOT's effects on things beyond smoking, such as mental health, needed to be researched. This indicates that although NOT is extremely effective in helping adolescents improve tobacco cessation and stress reduction, it may not have the same effect on individuals with comorbidity in mental health and tobacco use. This may be especially true if the individual is smoking to help cope with their mental health symptoms. So overall, NOT still really has a lot of growing to do and a lot of research that needs to be done. So I thank you all for listening to my presentation. Please be sure to check the slides of references that I've included for you that I've used throughout the presentation. I look forward to hearing your questions and engaging in an awesome discussion with you about what you learned about the NOT program. So thank you again.